Hello, and welcome to the Healthcare Transformation Task Force's webinar series, The Transformation to Value. My name is Claire Roble, and I'm the Director of Payment Reform Models with the Healthcare Transformation Task Force based in Washington, D.C. I'll be your moderator for today's webinar. Before we begin today, I'm just going to take a moment to orient you to the Zoom webinar platform. If you'd like to ask a question to our presenters today, or if you have any kind of technical concern, please type your question or concern in the question box on the Zoom screen. Our team will be tracking the questions that arise, and during interludes in the presentation, we'll select questions for the presenters to answer. We will have a formal Q&A at the end of the presentation where you'll have an additional opportunity to send in any questions. And one final logistical item, this webinar is being recorded and will be posted to our website within 24 hours. So let's introduce our panelists. Today we are joined by Danielle Lloyd, who is the Vice President of Policy and Advocacy for Premier. Danielle leads Premier's policy, analysis, and development. She's a national expert on federal healthcare quality and payment policies, and also a member of the Task Force's Executive Committee. Thanks for being with us, Danielle. And we're also joined by two executives from Atrius Health. Marcy Sindel leads the ongoing work of defining and articulating the Atrius Health strategy, and Dr. Richard Lopez, who works collaboratively with clinical and administrative leadership to advance population health and care management initiatives for Atrius Health. Thank you to both Marcy and Richard for joining us today. Now I'm just going to give a brief overview of the topics that we'll be covering today. We are going to be introducing you to the Healthcare Transformation Task Force, if you're not familiar with our work, and then going over the Levers of Successful ACOs report, which is a project that was recently released by the task force. And Danielle Lloyd will be sharing the project overview and some of our findings. And there will be, throughout the presentation, the Atrius Health executives will be sharing a case study on how Atrius has achieved high success under the Pioneer ACO program and now moving into the next generation ACO program. And finally, we'll have time for Q&A and introduce a new resource from the task force. The task force is an industry consortium bringing together patients, payers, providers, and purchasers to align the private and public health care systems in accelerating the transformation to value. Our aspiration of our members is to have 75% of businesses operating under value-based payment arrangements by 2020. This next slide shows you some of our members across the, as we call them, 4P categories: patients, payers, providers, and purchasers. As you can see, representing both regional and national healthcare players, as well as consumer advocacy groups and large employers. So with that, I'm going to transition to Danielle Lloyd from Premier to take us through the Levers of Successful ACOs report. Danielle?
Thanks so much, Claire. Good afternoon, everyone. Again, I'm Danielle Lloyd with Premier, and I have had the honor and privilege of participating in the task force and as a co-chair of the ACO work group since its inception. And my interest and knowledge related to ACOs really comes from our work here at Premier with our Population Health Collaborative that brings together 74 health systems, including 522 hospitals. And this particular project came to be because of the work group's goal of growing participation in and the success of the ACO model. And specifically, we wanted to look at the common practices of the high performers to really ease the transition into the program for the new participants, particularly smaller organizations with less access to capital, by providing some concrete guidance on, what's actually working out there. We also wanted to assist with hastening success among the existing participants by sharing insights from the high performers to low performers, and honestly from the high performers to high performers, because really no one is good at everything, and certainly we all have room to grow. So To start, we had to define high performance so that we could identify participants. And you can see here the organizations needed to achieve at least 2% in savings, high quality, not have a super high baseline that made it particularly easier, to generate savings, and had at least 5,000 beneficiaries, and also to have at least 1 year as an ACO, some experience, and at least one commercial contract in addition to Medicare. And then lastly, the geographic diversity. And on this next slide, you'll see on who we identified and who participated in our qualitative interviews. There were 11 ACOs. They're listed here and their locations, and you can see we have a pretty decent geographic spread. And also I will note that we had also a mix of both provider-led and hospital-led integrated ACOs. So moving to the top line findings on the next slide, we're going to cover the findings of each of these reports in more detail throughout the webinar. And as Claire said, our friends from Atreus will be sharing their experiences in each of these areas. But basically, in a nutshell, after conducting the interviews and determining these commonalities, we broke things up into 4 parts. The first, we wanted to basically level set with background information and details on how we set up the research, including our methodologies. Second, we chose to start in terms of detailing the commonalities by focusing on culture. And we all know the saying, culture eats strategy for lunch, and that is very true here in terms of moving to population health models requires a very significant change in practice. The third part, we laid out the proactive population health management strategies employed, including, in particular, the identification of high-risk patients before they seek care, case management, and patient engagement efforts. And then finally, in part 4, we looked at the structure for continuous improvement. What are the strategies for that ongoing performance improvement, such as training and feedback and altering incentives? And so one thing I will also point out here is that the reports are available on our website, hcttf.org, or, standing for Healthcare Transformation Task Force. So now we're going to go ahead and move on to Marcy and Marcy Sindel and Richard Lopez to introduce Atreus.
Good afternoon. Thank you, Danielle. And thank you to the task force for inviting us to talk about our experience at Atrius Health as an ACO. Atrius Health, through our medical practices, which some of you may know as Harvard Vanguard Medical Associates, Dedham Medical Associates, Granite Medical Group, and PMG Physician Associates, has been a value leader for decades. We're located in eastern Massachusetts with a territory that spreads from the New Hampshire border to the bridge heading on to the Cape, and then west to almost 495. And I note that one of the success criteria is a diverse geographic area. For anyone who's spent time in Massachusetts, you'll know that there's a big difference between Chelmsford, Boston, and Plymouth. That's our diversity. We do have a diverse population. We care for about 740,000 adult and pediatric patients. We have 6,800 employees, including 900 physicians, representing 50 specialties across 30 clinical practices. We are independent of a hospital or health plan, although we collaborate with both. We're nonprofit and have a large VNA that has home health, palliative care, and hospice, which we believe is a big differentiator for us. And you'll hear Rick talk as he goes through some of the later discussion about the work we've done with the VNA care. What makes us a real value system is that we have 75% of our $1.9 billion in gross revenue in full risk contracts across the whole continuum of care. So even though we are an ambulatory practice with home health, we're taking risk on hospital care, skilled nursing, and other post-acute care, other specialists, and pharmacy, and in some cases, behavioral health. We've been a pioneer over the past 5 years, and ended in our 5th year with about 3.4% savings rate and the highest quality scores amongst the Pioneer ACOs. If you go to the next slide, we believe that our legacy as a multi-specialty practice is really a big part of what enables us to be a value leader. We define ourselves as a primary care foundation, with about half of our practice being in primary care, and are very well integrated specialists supporting that primary care. We have a behavioral health program with about 100 clinicians that's well integrated with primary care, and then an infrastructure that Rick will talk a little more about later, but that includes everything from clinical pharmacists to chronic disease management, essential laboratory, imaging, pharmacy on site, and 24/7 telephone access and urgent care. We were here in Massachusetts among the first to adopt what's known pretty well nationally as the Blue Cross Blue Shield of Massachusetts Alternative Quality Contract, or AQC, back in 2009. Although we'd had very similar kinds of contracts with Blue Cross for many years, with the exception of the quality metrics program that they put in place, which is a little different. And we're now in Next Gen, and Massachusetts is about to launch a new Mass Health ACO program in January, and we are working with Tufts Health Plan on as a Mass Health ACO, so we're going to learn how to work with district dollars. And so that provides us with a very big incentive to move care out of the hospital to lower cost settings. We're also a very big Epic shop. Harvard Vanguard was actually on an electronic medical record back in 1969, and we've been on Epic since the mid-90s. We've had a data warehouse for about 15 years, and we're HIMSS Stage 7 recognized and do predictive analytic work and a lot of decision support. Next slide. We're very team-based. We have many advanced practice clinicians in the practice, and we have other roles that are used for outreach or for coordinating care in the community, as well as a group that goes into the home to care for patients who are homebound or for a temporary or longer period of time. We have been certified since 2008 as a level 3 patient-centered medical home across most of our practices, re-upped in 2011, and at the moment are not certified, but we stay very close to the standards. We have a set of preferred hospitals who we work with closely and have the ability to share electronic medical records through a web portal that allows for one-click access that we use about 135,000 times a month. And then, as I mentioned, we work to move care into the home. Next slide.
Okay, I think I'm going to go ahead. This is Danielle, and move on to the first theme here. So again, you know, what are high-performing ACOs doing, and you know, what do they believe has helped them achieve success? So the first common theme again here is the achieving high-value culture. And the first lever, we're putting this obviously with the title of the paper. We're identifying the particular levers we think people can utilize to be successful. The first lever is the pre-ACO activities. And, you know, through our interviews, we found the culture of the board is paramount in moving the direction of population health. There are certainly risks involved in taking this journey, and it really requires the full commitment, not just by the organization, but the board itself to really effectuate the strategy and be successful. In addition, previous contracts with other payers have also enabled the ACOs to really build off of their existing experience and structures. And this doesn't have to be, you know, full capitation or really significant downside risk. In some cases, respondents felt that they're value-based contracts that include measurement of quality outcomes can be a stepping stone as well. The second lever is active participation by senior leaders. And within that, aligning the governance bodies for multiple ACOs can be beneficial. As you might imagine, having centralized governance structure allows for the creation of common goals across different types of participants and organizations, right? Really gets the buy-in of the groups. And alignment across various value contracts is important as well. So, to the extent that there's similarities in terms and measures and et cetera, that certainly streamlines things if there's the commonalities across those. And then setting expectations for senior leaders to drive, that it's really their responsibility to drive the quality and efficiency strategy. And similarly, it can be helpful also, not just with the governance, but it can be helpful to have centralized ACO operations rather than, adding a bit of responsibility to each different staffer within the existing organizations or each unit, right? But this was not universal among the groups. But I will say, at a dinner table with some folks recently, someone said, "Oh, I work at the actual ACO level." And all the other ACO participants at the table were quite jealous because they really felt that dedicated staff and overall operations was very important. In addition, most organizations use a clinical and administrative dyad structure to governance. A colleague of mine puts it this way: physician-led, professionally managed. That pairing of the clinical and administrative staff can be helpful. And an example would be, let's say there's contract terms that maybe they're considering changing. You'd bring a representative of the providers, the clinicians in the hospitals, as well as someone from the finance team to really go through what would be the ramifications, both operationally and clinically, of such a change. And certainly involving patients in practice redesign is key, and bringing them in from the ground up as partners. The third lever here is the physician and community practice engagement. And to get buy-in from the clinicians, you really, the ACOs really need to make sure that they are co-creating the implementation strategies through a really collaborative process. And it helps to devise subgroups. Sometimes these are clinical subgroups, sometimes they're geographical subgroups, depends on the ACO, for the purposes of education and performance measurement. So some of that can be more targeted. And this is one I've heard time and time again, but start with champions. Find those physician advocates who really believe in this journey to convey the ACO policies and requirements. It comes better from a peer who can clearly articulate it from a common perspective. And lastly, establishing a parsimonious set of actionable performance measures. You can't boil the ocean. You got to pick where you have a champion, where you have a large opportunity, and really focus on some particular areas. The fourth lever is expanded clinical partnerships. And this goes beyond physicians and hospitals in identifying and engaging high-performing post-acute care organizations, long-term care providers, so skilled nursing, home health, et cetera. If you, for instance, find you have a particular skilled nursing facility that is readmitting a significant number of patients, what can you do about that? Can you help that particular skilled nursing facility improve or establish relationships with other skilled nursing facilities? But you have to find that high-value network, broadly across the continuum. And maybe that's embedding, in that SNF case, maybe that's embedding a nurse case manager, as it says here. But the crux is looking outside your respective four walls for partnerships across the continuum. And lastly, the importance of integrating behavioral health within primary care to really better manage comorbidities. And, certainly, as I said before, culture change can be very difficult. It does not happen overnight. but we believe, based on this research, that building strong partnerships and building this high-value culture is absolutely an imperative one to success. So, Marcy and Richard.
Thank you, Danielle. So you outlined very well, some of the key factors in putting together our program. And I'm going to walk through those same factors and talk about the Atreus Experience. I think even before we joined the Pioneer ACO, we had a long experience with Medicare Advantage and commercial risk that I think served us well in terms of understanding the fundamentals of value-based care. When we became part of the Pioneer program, despite our experience, there certainly was a degree of anxiety and anticipation about managing the care of a large number of Medicare PPO patients, where we did not have typically the direct control that one would have in an HMO product. And so there was a lot of emphasis at the most senior levels of the organization that this was a priority. They demonstrated that in a couple ways. One was that the Atrius Health Board became also the Pioneer Board. So at every board meeting, a segment of the time of the agenda was devoted to Pioneer-related questions and issues and performance sharing. Another sign of that commitment was that we did create a small central team to help push our efforts forward. So this included an experienced director who had a lot of experience with managed care, some analysts who were able to generate trackers and performance and do the kind of information gathering you need to form the basis of clinical programming. The team also included a couple project managers to support the efforts of the work groups, as well as Epic analysts. And a lot of the work we do is tied with the way we've configured our EMR, the Epicare. And so having analysts who could do configurations quickly and get those online was important. With respect to physician engagement, we did, in fact, identify champions from each of the practices. And so we had many locations, we still do. And so each of these locations have an internal medicine practice. And so what we did was we asked for a physician who could be a champion, and the role of the champion was severalfold. First was to continuously convey all the activities and changes that were coming out of our initiatives to each of the internists or primary care practitioners at that site, so that everybody was aware. And this helped generate excitement, interest, and ongoing efforts. Secondly, we pulled the second sort of role of the champions was educational. So part of performing well required us to up our game in terms of the practice of geriatrics for the Pioneer program. And so we did a lot of train the trainers and had the champions out at the sites doing that training for clinicians in various aspects of geriatric care. We had a monthly ACO day where we would bring the ACO champions, clinical leaders, directors of care coordination programs, and work group participants, and I'm going to talk about the work groups in a minute, to hear what was going on. And so this was a fairly large meeting. It was probably 50 to 60 people, happened religiously every month for half a morning. And typically the first hour or two would be presentations about what was going on, sharing the best practices. breakout sessions to discuss problems that people were encountering, but it really served to generate a lot of enthusiasm and kept the lines of communication open. In the second half of that morning, the work groups that we had formed came together, so it was a convenient time for us to pull together those groups. The groups were determined based on some of our pre-ACO work, which was trying to decide and understand what were the most fertile areas for opportunity for better management of care. And the areas that we came up with were managing patients in skilled nursing facilities, managing patients in the home, and better skill sets and knowledge and execution around end-of-life care, palliative care, and the use of hospice. So those three areas were three key initiatives that we felt on a functional basis were important for us to do better in. As a result of, and these work groups, by the way, were made up of clinical leaders, nursing, some frontline clinicians who had a particular interest, and they would meet as well on ACO Day. As a result of those work groups' efforts, we've done several things. One is we built a preferred skilled nursing facility network. We identified where our patients were going. We had over 50 or 60 facilities that they were going to. We narrowed it down based on facility performance and geographically where our patients needed to be. And so now we have a skilled nursing facility network of about 25 facilities that are staffed, half of which are staffed by our own physicians and nurse practitioners. We developed standards for the SNF providers. We developed standards for the SNF facilities. And we bring together the SNF facilities on a regular basis, several times a year, to talk about their performance. And we do performance improvement plans when their performance is faltering. We also did a lot of work with VNA Care, our VNA subsidiary. We developed a one-time home assessment model where we could have the VNA go in to see a patient to do a home assessment that was not attached to a certified episode. We developed another model that was more acute, where a VNA nurse could go into the home within 2 hours, where there was a question with a geriatric patient about whether they needed to go to the emergency room or not, and she would report back her findings, and we found this program very successful in saving ED visits and admissions. We've also worked with our VNA around telemonitoring at home and have expanded that program significantly. And on the palliative care, advanced care planning side of things, we did a lot of educational sessions, educating on not only health proxies, but medical orders for life-sustaining treatment, trainings around hospice, developing a home and office-based palliative care model, and developing prompts within our system to have clinicians think about when they should be having those discussions. And so all of that work came out of those work groups that we had put together on a functional basis. Danielle?
Okay, thanks, Richard. So the second theme we want to go over here is the proactive population health management. And the first lever here is a system for identifying high-risk patients. So not waiting until the next time someone actually seeks care, but being proactive about it by establishing and utilizing standard risk models based on claims and clinical data to stratify the patients and devise their new outreach, devise outreach to them and devise new care plans. And perhaps for a subset of high-risk patients, you reach out to them to participate in disease management programs, as an example that we'll talk about later. And there are a variety of tools out there to do this. Some folks have even noted creating their own homegrown analytics. The other thing is regularly testing and refining the risk model. This is certainly an evolving science, and your care patterns will be changing. So it seems that employing continuous improvement, even here to the risk stratification, is warranted. And also integrating real-time data sources where possible. An example being the ADT or admit discharge transfer feeds. Following ED use as an example as well can in and of itself provide important data, albeit rough. And making the risk score actionable for the clinicians and case managers, using it as decision support here. So, you know, as one person said, I'm paraphrasing, but you have to be pragmatic about it. We can't afford to do everything for everybody. So, you know, along those lines, you know, you can't just hand clinicians a laundry list of patients, but you really have to look at, you know, segmenting the list and pairing it with options, community options and otherwise for that clinician to employ. The second lever is general care management functions. And when asked about what care delivery changes had most meaningfully and directly contributed to the success of the ACO, the executives we spoke with cited pretty much universally the importance of care managers. And especially you have to think about redefining the care management role under this new construct of accountable care. And that potentially means recruiting new staff, possibly retraining existing staff to meet the new objectives of accountable care. And this could be done through a combination of centralized and embedded services, or one or the other, to make efficient use of time with the patients, and also to make sure that you're on an ongoing basis evaluating the needs of these patients to see if anything needs to change. Some of the suggestions for where embedding care managers might be a good idea were the emergency department, skilled nursing facilities, and also on inpatient rounds and care team huddles to support both patient education and transitions of care. The third lever is specific disease management programs. First, to identify priority conditions for the ACO population. So we heard from the respondents, it's often diabetes, congestive heart failure, COPD, chronic kidney failure. And as part of this, you have to develop a way to track and refer patients to the programs. You also have to engage clinicians around the clinical care protocols that might be changing and how to close the care gaps. Educating patients, particularly around self-management for chronic conditions. And lastly, teamwork, ensuring care management staff that have overlapping responsibility for the same patients are actually coordinating. So the ACOs that we spoke with really have invested quite heavily in infrastructure to address cost and quality variation and opportunities for improvement. And these methods have, they believe, are part of their success at least under the Medicare contracts. So with that, Marcy and Richard.
Thank you, Danielle. You know, a lot of our work was based on our experience with our Medicare Advantage population. We have been in Medicare Advantage for a long time. We've built infrastructure like case management and home-based programs with nurse practitioners and skilled nursing facility staffing. And I think what we found was that actually one of the incentives of moving to the Pioneer program was the ability for us to care for all of our Medicare patients the same. I think for a number of years, we kind of felt that we managed our Medicare Advantage patients differently than our Medicare fee-for-service. And so becoming a Pioneer allowed us to have a more uniform program. What was interesting as it played out over the 5 years is that by improving our ability to care for the Pioneer patients, because there was such an intense focus, had a beneficial effect on the performance of our Medicare Advantage patients, that we actually did a better job on them as well as our Pioneer patients. So it worked out well across the board. Some of the things we did in our population health management, one was certainly to develop a high-risk report. And early on, we used a number of simple parameters with a points scoring system to identify high-risk geriatric patients. And we provided the practices and case managers an updated monthly list of these high-risk patients so that the case managers could outreach to the patients and determine if they needed to be followed over time with close care coordination. We also use those high-risk reports to help support what we call geriatric roster reviews, where we would have, on a regular basis, small groups of a PCP, a case manager, social worker, maybe a clinical pharmacist, come together and review several high-risk geriatric patients to make sure that the care plan was optimized for those patients. Another piece of work we did in working with the VNA was to ask them to make sure they did a depression screen, a fall risk assessment, and completed a healthcare proxy for all of our geriatric patients that were seen in a certified episode. Similarly, we incorporated within EPIC a decision support that ensured that when our patients came in to be seen, even before they were seen by the clinician, the medical assistant would make sure the patient got a health proxy form, would do a fall risk assessment, a brief screening fall risk assessment, would do a PHQ-2 screening assessment for depression, which helped sort of prompt the visit for the clinician with this additional knowledge. We did some work also around early identification of chronic kidney disease and put in supports to make sure those patients who had certainly stage 4 and sometimes stage 3B chronic kidney disease got nephrology referrals and had the appropriate lab testing done on a regular basis. If you go to the next slide, some of the outcomes of this work in terms of our skilled nursing facilities. One was the reduction in the average length of stay for our patients in the SNFs over a 4-year period. In blue is our Pioneer patients, and in red is our Tufts Medicare Preferred or Medicare Advantage patients. Obviously, they have lower lengths of stay because of our the Medicare product they're in and our ability to manage it more closely. But both cohorts improved in that performance, as were their improvements in the SNF readmission rate. And I would attribute these improvements directly to that work of the work groups that I talked about, where they developed standards, metrics, and provided regular feedback to the SNF facilities and the SNF teams. On the next slide shows our work around improving referrals to our preferred VNA, which is VNA Care, which is a subsidiary of Atrius Health. And again, you can see the referrals increased compared to over the 4-year period. And this was important not only to keep these patients within our network, but because we had developed a series of standalone, unique, and innovative programs with the VNA, the more patients we could have being cared for our VNA care, the more opportunity there was to use those programs improving the care of our patients. On the next slide is a sort of pictorial representation of a skill set I think we've developed in the last 2 or 3 years to advance our predictive analytics to identify high-risk patients. Basically, what this entails is taking a set of data from our claims-based data warehouse and our EMR and looking at up to 500 to 600 different variables and doing regression analyses to identify populations who are at high risk. And these predictive models have turned out to be fairly accurate. We've developed them, we've developed a series of them. So one predicts the greater than 30% risk of admission to the hospital in the next 6 months. And so that's a cohort of patients that we can identify and act on, and I'll talk a little bit about that in a minute. Second is another model which identifies the risk of dying in the next 12 months, which is a model that can be used to help facilitate advanced care planning and palliative care consults. Another model looks at the risk of generating more than $100,000 in medical expense over the next 12 months. And lastly, in a more recent model, is identifying patients who at the time of admission are at very high risk of a readmission. And in all of these models, we've used them in different ways to tackle our high-risk population. So as an example, if you go to the next slide, around providing information to clinicians around what we've called the purple people. So these are patients who are at high risk of admission in the next 6 months. And in order to make this actionable, what we've done is created a purple banner within the electronic medical record, which stands out in stark contrast to the usual yellow banner, and immediately alerts a medical assistant, a nurse triage, or a clinician that this patient is a high-risk patient. We've developed protocols around that, and one example is that when these patients call in with an acute medical issue, we have a protocol where their problem gets addressed during that single phone call with a warm handoff to a nurse for further triaging if necessary, as opposed to taking a message and calling them back later when they may have by that time gone to the emergency room. So that's an example of taking these high-risk predictive models and using them in the clinical practice. We also provide a host of other types of information for our clinicians. So they get monthly quality reports around their hypertensive, diabetic, and cardiovascular disease management. They get quarterly cost reports around the cost of their highest cost patients, identifying patients who are frequent flyers to the emergency room or the hospital. We also provide quarterly Press Ganey reports of their patient care experience. We have rosters developed into our electronic medical record. So as a PCP, I can pull up my list of diabetic patients, my list of hypertensive patients, my list of chronic obstructive pulmonary disease patients. We also have a daily hospital census that is available within the EMR based on the ADT feeds we get from our preferred hospitals. I think it was mentioned earlier that we have two-way web portals with our preferred hospitals that allow easy access to medical information. All of this is providing actionable information to our clinicians. Danielle?
Thanks, Richard. So the third And final theme here is the structure for continuous improvement. And the first lever within that is operational infrastructure for performance measurement. So dedicating data and actuarial analyses and performance improvement resources specific to the ACO efforts. I'm sure you all are already doing this for your services. The question is, are you doing it across the continuum? And identifying a few key high priority areas using that objective data to focus on just a few things at a time. One approach is to look at commonalities also across your ACO contracts, if you've got multiple contracts, with regards to things like performance metrics, as an example, to maximize the impact of your interventions, right? So if you can try to find the things that are going to help you succeed under multiple contracts. You also have to integrate the analytics with the performance improvement opportunities and the clinical staff to design, pilot, and evaluate new workflows. Certainly, we've heard that these are iterative processes, and you may not hit it out of the park at first. And key to this is having the right staff. So both for the analytics and the dedicated quality improvement staff. In fact, these staff were cited second to only the case managers, as I mentioned before, as one of the most important aspects of successful care change. The second lever is tying performance to compensation and network contracts. Certainly the overall changes to the ACO payment level are necessary but not sufficient. If you have to ensure you have to also ensure that the incentives and thus the culture are also passed down through the incentives and through identifying the right partners. And it helps, of course, to have a way to benefit those physician champions who are putting in time outside of billable hours. Incorporating key quality and utilization metrics into the compensation plans for those employed physicians, and potentially, we heard this from some folks, making some of the results public to encourage the behavior change. Now, I think that's more within the system, but establishing also separate funding pools to incentivize primary care process changes, and an example given there by respondents was coding accuracy. And developing network criteria for affiliated post-acute care providers and specialist referrals. And we talked about that a little bit before, of building your high-value network. The third lever is participation in shared learning opportunities. Clearly, myself and Premier subscribe to this point. There are various voluntary learning collaboratives around the country for best practice sharing and addressing common challenges. You can participate in a national consortium for easy access to content and expertise, and where you don't get from participation in those larger groups, that's where you then would be able to go and then seek individualized consulting resources and publications for data analyses and implementation guides, etc. And so what we see from respondents here, the ACO model demands this concept of continuous improvement in essentially all facets. So ACOs have to be continually mining the data, constantly finding the new opportunities and iterating on the care changes to really achieve ongoing successes and not just one-time successes. Richard?
Yes, so I talked earlier about when we first entered the Pioneer ACO that we created a small team to help coordinate the initiatives. And what's happened over time as we progressed through the Pioneer and taken on NextGen is that we identified the need to have a larger central team, which we've called the Performance Excellence Team, which would help support the service lines around the various domains of quality, patient safety, patient experience, and medical management. And what this team does with its complement of several medical directors, analysts, project managers, and staff is they support our ACO activities for both commercial, Medicare, and Medicaid ACOs around these functional domains. So they help set targets, they mine the data and identify opportunities, they act as a convening entity to share best practices. They provide project management support for initiatives related to our ACO activities. So basically, it's like, I would think of it as an internal consulting group that is available for population health related activities in these domains for the service lines. I'm going to turn it over to Marcy to talk a little bit about value-based payments.
Next slide, please. So this is really in our DNA. This is an organization that has been doing managed care for the most part since it began, although some of the groups that we've brought on come from a bit more of a fee-for-service environment. But managing care, ACO care, is really how we do things. So I'd love to tell you that we have discovered the secret for physician compensation. In fact, this is where we, like everyone else, have kind of one foot in each canoe. So our physicians are largely employed. All of the primary care physicians are employed, and all but a small number of specialty physicians are employed. So we have a physician compensation committee that's made up of physicians from each of the specialties, and they determine their own compensation formula. The primary care docs have 10% of their compensation that's based on quality and patient experience, but we don't pay out savings from our ACO contracts. They just go back into the big pool to support the practice. I think the incentives are a little more intrinsic. One of them is that we really have this philosophy to treat all of our patients the same in a payer-blind way, so that the clinician doesn't have to worry that this is an ACO contract and they have to do something different from the patients who are not on an ACO contract. And that leaves it to the management team then to address the fun challenge of sizing the infrastructure properly. I mean, in a lot of ways, our risk contracts really are subsidizing this extra non-billable care for our fee-for-service patients as well. We do have a big annual focus on total medical expense, and just to give you a couple of examples of how this plays out, and these are very much in the specialties as well as in primary care. We recently had an ambulatory migration project where we looked at all of the care that we could move from academic medical centers to community hospitals, from higher cost community hospitals to lower cost community hospitals, or to ambulatory surgery centers, or to freestanding ambulatory surgery centers, and also into the office practice. So as an example, we do trigger finger within the practice. We also, as a second example, did a lot of work around total joint replacements, where we shifted from using post-acute skilled nursing facilities to using home health and having our VNA go in ahead of a total joint replacement, do an assessment so that we could send as many people as possible home afterwards with home health. Teledermatology is another example. So our specialists in dermatology and e-consults and other specialists, we pay them an RVU to take questions from primary care physicians and in a pool, and then to recommend a treatment with documentation in the electronic medical record back to the patient. And now we're working on hospital at home. So everyone knows that our goal is to reduce total medical expense and to improve quality at every level. And it really is built into the culture. And I'll stop there to leave a few minutes if there are questions.
Thanks, Marcy. I think we will move on now. We have a few minutes for questions, and we have a few already in the question box, but if folks have others, please do enter those now. So I'll start with one about technology, since that was touched upon a few different times. So one question we did receive was, how much of the population health management efforts were enabled by technology versus enhanced or accelerated by technology? Marcy or Richard, do you want to take that one?
Yeah, you know, it's probably not one or the other, but what I would say is our technology has accelerated. I would lean more towards the technology has accelerated our population health management. You know, the ability to configure designs within our EMR that support point of service care, and our ability to use the data in our data warehouse for these advanced analytics that I talked about are really, you know, well beyond the technology we had 5 years ago, and do advance our population health efforts.
Yeah, and I think when we think about our workflows, I mean, it really is embedded in Epic. If somebody wanted to pick up what we do, they'd have to really pick up our Epic medical record and how it's been configured with all of the fields and alerts and so forth.
Great. So another one, we had gotten a couple questions about addressing social services. So just a question around any current efforts or plans to screen for health-related social needs, and any efforts that you have in place to address social issues such as transportation, food, or housing.
Yeah, so we've done a little bit in this space with, particularly in pediatrics and in behavioral health, where we have care facilitators in pediatrics, and they've identified patients largely from our Medicaid population who need additional help, and the pediatricians can refer patients and families to these care facilitators, who then will work in a pilot case with a community health worker to find opportunities in the community. And then we have social workers in the practice as well who can support that. We haven't done it as much in a truly structured way, and so one of our efforts as we enter into this new Medicaid ACO is going to be to take a social needs determinants of health assessment and add it into the screening for our Medicaid patients, and then begin to build more structured programs around that.
Yeah, our hope is to be able to do it in a more widespread way, and I think this Medicaid ACO work that we're undertaking is really going to drive that process to create this set of data within our EMR, which I think will not only help clinicians understand what their patient needs are, but also add to our predictive analytics.
And I would just add, because I see that there's a question about some of the care team. We do have a number of social workers who are tapped into largely by our case managers, and in some cases by the physicians. We have about 13 clinical pharmacists who do academic detailing and will work with patients who are having trouble paying for their medications. So certainly that's one of the social needs. And then we just have right now one community health worker who's a contracted person from one of the local aging access points, and we're going to be looking to do more of that as we get funding from DSRIP through Medicaid.
I would add that Marcy had mentioned about the pediatric care facilitators. We have a half dozen of them, and similar number of behavioral health care facilitators, and about 4 in case management. And these are all non-licensed individuals who have some clinical experience in some setting. They may have been medical assistants or college students who graduated and want to go into healthcare. And we have found them to be very helpful in dealing with social determinants of health, helping to coordinate some of the non-medical issues that high-risk patients, either adult, pediatric, or behavioral health have. And I think we're going to be moving more towards that in terms of lower cost support for care coordination, rather than using more costly, let's say, RN case managers.
And this is Danielle. I'll just echo the use of the non-clinician community workers is very common among our membership as well. Certainly, help with transportation is super common, although some legal issues there that folks are trying to work through. And some of the participants are working with local food pantries to ensure, sort of nutritional and food security, as well as, other organizations. And then lastly, the housing piece, there are a couple that are working on housing. Obviously, that is a capital intensive endeavor, but there are some who are moving that way. It's really among really the most advanced organizations.
Thanks, Danielle. And since we're at the top of the hour, sorry we weren't able to get to all questions, but we will send those along to our presenters. And the last slide we just want to get to quickly is to introduce to you a new resource. The Healthcare Transformation Task Force has partnered with the New England Journal of Medicine Catalyst blog to offer an analysis of how value-based care has positively disrupted the U.S. healthcare economy. So at the websites you see on your screen, both at the NEJM Catalyst website as well as the hcttf.org, there are a series of reports on how value has impacted patients, providers, payers, purchasers, and partner organizations. These pieces have been released over the course of the past few weeks and are now available on our website as well as the NEJM Catalyst website. So with that, I will thank you all for joining us today. Thank you again to our terrific panelists and for all of you that engaged with us in the Q&A session. Thanks again and have a wonderful day.
Thank you.
Thank you.